We are live now, doctor.
Okay, so I welcome everyone. Second episode of Uvea Case Conclave, and this is a humble group that we have created as young ophthalmologists, focusing on basic nuances and classic cases of uvea. This we are very thankful to the YOSI Governing Council for giving us this opportunity. So this basically this group focuses on encouraging the young ophthalmologists and getting them an idea about uvea, how to manage it. We are focusing on making a fellowship database that is basically focused on uvea fellowship, that is very less in Indian scenario that we have. Webinars like this actually will help general ophthalmologists and regular fellows that are struggling with uvea cases during their fellowship. Learning modules will help in building up the diagnosis as well as the treatment. And we have a WhatsApp group with more than 300 participants where we have more than 200 participants by now. Every Monday we share classic spotters, and every Thursday we try and update everyone regarding the new updated articles. So today, in our second episode, I welcome Dr. Mohit Dogra sir, who is well known for his teachings for vitreoretina fellows, as well as he is a part of teaching of MCH vitreoretina in one of the first programs in India, that is PGI Chandigarh. Along with his great research experience of around 120 plus researchers, he is known for his teaching as well as his humors amongst his peers and his students. He is co-investigators in 8 multicentric drug trials as well as in 3 ongoing extramural research projects. And he has been chief guide in few MS ophthalmology theses also. We welcome you, sir. Uh, I would like to welcome our speaker, Mr. Dr. Ashwin PR, who is presently consultant in vitreoretina services at Arvind Eye Hospital, Tirunelveli. He has done his MS from Arvind Eye Hospital, Madurai, and his fellowship under Dr. Syed at Arvind Eye Hospital, Tirunelveli. Welcome, Dr. Ashwin. Please feel free to share your uh, case with us.
Thank you, Dr. Pallavi, and thank you, YOSI, for giving me this opportunity. I'll just share my screen. Am I audible?
Yes, you're
Yeah.
audible.
Yes, sir.
So I will talk about my case of a bilateral acute retinal necrosis. This is a 44-year-old male who presented with sudden onset simultaneous defective vision, left eye more than right eye for 2 weeks with pain. He had given history that he had lost his peripheral vision first, followed by central vision. No history of flashes, floaters, or trauma. No history of any hearing loss or skin lesions. He gives history of fever 1 week prior to the vision loss, for which he was treated initially in a local PHC and he was given IV fluids. He was seen initially in another hospital where this is the OCT findings, which shows macular edema, neurosensory detachment, and you can also see there is some amount of inner retinal layer hyperreflectivity. So initially he was diagnosed as a case of combined vascular occlusion and evaluated in detail for the same. But then later on, as he developed features of... am I audible? Yeah.
Yes.
Yeah. So later on, as he developed features of uveitis, he was again re-diagnosed as VKH and given IVMP 3 doses, along with that followed by oral prednisolone 40 milligrams per day in tapering doses. And then he was referred to us because there was no improvement in vision. So when he presented to us, he had nil perception of light in both eyes. The anterior chamber is in fact quiet when he came to us. The pupil was ill-sustained and intraocular pressure was normal. But this is the fundus picture. As you can see, the media is quite clear. There is disc hyperemia. There is some amount of retinal arteriolar attenuation. You can see some cattle tracking going on. There is diffuse areas of retinal necrosis bilaterally, along with perivascular clearing. And then there is also a lot of hemorrhages. And you can see both eyes, there is macular ischemia. This is the OCT of the right eye macula that shows again macular edema, inner retinal layer hyperreflectivity, amount of retinal necrosis, and neurosensory detachment. This is the left eye, which also shows similar findings of neurosensory detachment, inner retinal layer hyperreflectivity. You can also see some posterior vitreous cells and edema. So this is the fundus fluorescein angiography of the right eye, which shows a delayed arm retinal time. And you can also see areas of hypofluorescence in the areas of capillary non-perfusion and blocked fluorescence due to the presence of hemorrhages. And in later phases, you can see diffuse hyperfluorescence in the areas of retinal inflammation. This is the fluorescent image of the left eye, which again shows similar areas of capillary non-perfusion, especially in the macular area, and then areas of blocked fluorescence corresponding to the areas of hemorrhages. And in later phases, there is hyperfluorescence due to the retinitis. On investigations, the ESR was within normal, ESR was slightly elevated. The rest of the investigations were within normal limits. The infection workup, HIV, HBsAg, HCV was all negative. MAN2 was 5x5. TPHA was also negative. We did a torch titer that showed mildly elevated toxoplasma IgG, HSV IgG, rubella IgG, and CMV IgG. But as IgM was negative, we didn't consider it to be contributory. Now, with the diagnosis of both eyes acute retinal necrosis, he was started on oral valcyclovir, 1 gram thrice daily. And he also underwent vitreous tap in both eyes for viral PCR, along with intravitreal ganciclovir, 2 milligrams and 0.1 ml. And he was also started on oral prednisolone, 40 milligrams per day, tapered weekly. So this is the microbiology report of the PCR from the vitreous sample of the right eye, which shows positive nested PCR of the herpes simplex as well as cytomegalovirus. And in the left eye, it shows positive only for herpes simplex virus. Now, on follow-up, the vision slightly improved with perception of light. The anterior chamber showed occasional cells, and the vitreous haze started increasing to 2+. And because CMV was positive, we shifted him to valganciclovir, 900 milligram BD, and he underwent bilateral sequential pars plana vitrectomy with silicone oil tamponade. So this is the post-operative photos. Vision is still perception of light. As you can see, there is diffuse areas of retinal thinning. There is also neovascularization and multiple membranes over the surface of the retina. And this is under oil. Now, just to recap the timeline, patient developed his fever and he was treated elsewhere with IV fluids, and then diagnosed initially as combined vascular occlusion, then later on re-diagnosed as VKH. He was given IV methylprednisolone. And then when he came to us, we diagnosed him as bilateral acute retinal necrosis, started on oral valcyclovir. Then he underwent bilateral vitreous tap, where it came positive for both HSV and CMV. And then he was shifted to valganciclovir and underwent bilateral sequential vitrectomy with oil tamponade. Now, coming to the discussion, acute retinal necrosis was first described in 1971 by Akira Urayama and colleagues. It's a clinical syndrome consisting of acute unilateral panuveitis, retinal periarteritis, diffuse necrotizing retinitis, and tegmental retinal detachment. Bond was first coined for bilateral cases of ARN by Young and Bird in 1978. Now, progressive outer retinal necrosis was initially diagnosed by Foster and colleagues, which is characterized by an infectious retinitis with a recent cutaneous zoster infection, limited intraocular inflammation, predominant outer retinal and posterior pole involvement. And the characteristic feature is that it happens in immunocompromised hosts. Now, ARN and PORN represent a continuum of fulminant viral-associated necrotizing retinitis in the immunocompetent and the immunocompromised hosts, respectively. Now, the American Uveitis Society gives guidelines for ARN, which is one or more foci of retinal necrosis with discrete borders located in the peripheral retina. There is a rapid progression of the disease in the absence of therapy with a circumferential spread. There is evidence of occlusive vasculopathy and arteriolar involvement and prominent inflammatory reaction in the vitreous and the anterior chamber. Supporting clinical criteria includes optic neuropathy, atrophy, scleritis, and pain. Now, ARN can get complicated because there is retinal necrosis. It can lead to retinal thinning, or can atrophy and cause breaks, which can progress to retinal detachment, which again gets complicated because of the presence of extensive proliferative vitreoretinopathy. Patients can also have chronic vitritis, macular edema, optic atrophy, and epiretinal membrane formation. Now, the agents commonly used in the treatment of acute retinal necrosis are acyclovir, valcyclovir, famciclovir, ganciclovir, valganciclovir, and foscarnet. Ganciclovir can also be given intravitreally. Now, this particular case, a few salient features I'd like to highlight here is one, there is simultaneous bilateral acute retinal necrosis. And then the two different viral etiology as confirmed by the vitreous PCR. The initial misdiagnosis as vein occlusion, combined occlusion followed by VKH. And then later on the added steroid effect of IVMP, which could have further worsened the situation. And then these features are similar to what you see in a progressive outer retinal necrosis, at least in terms of the way it has progressed. But then the patient has no other evidence of immunosuppression. Now, coming to the library of literature, bilateral acute retinal necrosis has also been described by Lee et al., wherein they found that the period to involvement of the contralateral eye can, on an average, be around 54 weeks, with 83% of patients developing within 5 months of the initial infection, and then in 16.7% developing after 2 years. Now, it can even happen years later, such as by Okunuki et al., who said that it can range from 3 years to nearly 19 years after the initial infection. And they said that the earlier diagnosis and better treatment contributed to better prognosis in the fellow eye. And they also suggested that immune reactions in the initial inflammation might prime immune cells working like a vaccination, which then functions to suppress the second infection. Now, Williams et al. Has also reported bilateral acute retinal necrosis caused by 2 separate viral etiologies, wherein a 67-year-old immunocompromised man developed varicella zoster retinitis in the left eye, and 4 months later developed Epstein-Barr virus in the right eye. The author suggested that immunocompromised patients are prone to developing infections by 2 different viral etiologies, and then that viral PCR should be taken from both eyes if indicated. Now, Takakura et al. Has also demonstrated viral retinitis following intraocular or periocular corticosteroid administration, wherein the indications of corticosteroid included vein occlusions, persistent inflammation, uveitic CMV, and immune recovery uveitis. And these patients, the author suggested, could be even a misdiagnosis, which could have worsened after the intravitreal or periocular corticosteroids. Now, systemic corticosteroids can also cause immunosuppression, wherein a patient who was initially treated for optic neuropathy with systemic corticosteroids later on developed progressive outer retinal necrosis. And then they said that whenever you have a doubt of patient having inflammation, it should be ARN should be kept in mind and then ruled out before you start any sort of steroids. And this is not only true for ARN, but for any infectious etiologies. Now, PORN can also happen in immunocompetent patients, as by Pacheco et al., who presented a bilateral PORN in a healthy male. Varicella zoster virus was confirmed on the basis of serology, and treatment was with intravenous acyclovir, and then oral prednisolone was also given, and it was successful. Now, Chawla et al. Has also demonstrated 2 patients who were initially treated with oral steroids for chororetinitis, later on developed clinical features suggestive of progressive outer retinal necrosis, and then later developed retinal detachment. In both these patients, HIU was negative, and they had a normal CD4 count. And the authors linked the possible steroid-induced immunosuppression followed by lack of initial antiviral treatment as to the reason why it progressed so fast. Now, a take-home points for this case: contralateral eye involvement can present simultaneously or sequentially in patients with ARN. Early diagnosis and treatment is thus crucial because ARN can be misdiagnosed if not evaluated properly. And ARN can also be caused by 2 different viral etiologies in the same patient. And viral PCR, especially on the vitreous sample, is useful in identifying the viral causes and should be taken from both eyes if there are features of retinitis in both eyes. Now, a few questions for the panelists or the moderators. Can you share some experience of similar presentations of ARN or bilateral ARN or bilateral PORN? And one question is, why does it happen in a perfectly healthy male when there is no evidence of immunocompromise? Possibly the steroids would have had alone. And then final thing, anything else that we could have done? I'd like to acknowledge Ratna ma'am, Syed sir, and Dr. Arif for helping me with this. Thank you.
Excellent presentation, Dr. Ashwin. Now I would like to ask Dr. Mohit sir regarding this case, that this patient was immunocompetent. So what could be the reason and the mean time between one eye involvement and the other eye involvement? When can we expect that in an immunocompetent patient, other eye involvement, when should we suspect that, and when to intervene with intravenous ganciclovir in these cases?
Yeah, I think very well presented, Dr. Ashwin. And I think good on you for presenting, extremely challenging case. The outcome unfortunately wasn't great, but I think there are lots of learnings from this. I think ARN is something which deserves a lot more attention. And thanks to YOSI and the Uvea interest group for putting this together, and Dr. Ashwin for actually presenting that. Now, coming to those 2 questions, Dr. Molly, I think 2 things. I think the word immunocompetent is, I think, used a bit too casually by all of us. And mind you, all of us, 80% of the world is exposed to herpes viruses in their system. They're just lying dormant. They could be in ganglia, trigeminal, elsewhere in the body, and even minor stressors can actually, kind of kick them into life and wake them up from dormancy. So I don't think that the immunocompromised part, as far as ARN is concerned, is a necessity. You do not need to be immunocompromised for you to get ARN. Absolutely healthy people with normal, TLCs, hemoglobins, CD4 counts, no issues at all, and all other parameters actually can get ARN just as frequently. You will see more non-immunocompromised ARNs in your career. I'm talking about patients than patients who actually have established diagnosis of either systemic immunosuppression or a iatrogenic immunosuppression, as was the case in this patient with who unfortunately went on to receive IV pulse steroids, which was almost the last nail in the coffin for this patient. I think all of us understand, and the diagnostic criteria were also highlighted in the presentation about ARN. It's a clinical diagnosis. It is something that one needs to look in the front and the back of the eye and make a clinical diagnosis there and then. If there is a suspicion, you might have patients that you tend to catch a bit early, or there might be a subset which have atypical presentations. Now, possibly this patient initially could have had one of those atypical presentations, which is commonly seen in younger and the so-called immunocompetent patients who have absolutely fine immune systems. More so with varicella zoster, but is also seen with herpes zoster, that not your typical multiple tongue-like necrotizing retinitis in the periphery, which tends to get confluent and will progress towards the posterior pole with panuveitis and inflammation of the arteries, but they just present with a combined occlusion, which can be a combined CRA or CRVO-like picture. So if you get something like that in a young adult and so sudden drop in vision, vision can be PL or no PL, and you will have whitening of the posterior pole and like a mild CRVO kind of picture because the blood's not being pumped into the eye. There is no venous stasis, which will cause a lot of blood to come out of the veins, right? But the vision will be precipitously low. That is also one of the presentations. Atypical, but not very uncommon, of necrotizing herpetic retinopathy. And they will keep on going, and sometimes it could just follow a dermatomal zoster, which could be on the upper lid or wherever. So I think that has to be kept in mind. And I think the first OCT showed that. I think with this patient had some edema and also had inner retinal hyperreflectivity, although we didn't have the photos from that. So I think this patient possibly had that. Why this patient was diagnosed as VKH is a mystery. I think VKH and ARN very seldom, if ever, would pose a diagnostic dilemma, except if you're only looking at the front of the eye, in which they could have, granulomatous inflammation anteriorly. Apart from that, there is hardly anything to confuse the two. And if there is one thing I think which should be definitely understood, is that if you don't know what the disease is, if you're not confident what the disease is, and if you don't know, and if it's rapidly progressing, please do not institute systemic or oral corticosteroids. Definitely not pulse steroids. We give them way too frequently in ophthalmology, I think, and we're all very comfortable giving them because thanks to our neuro-ophthalmology colleagues and the ONTT trial, and our physicians are good friends. But I think they should be used with a huge kind of a caution right next to them, because if you expose viruses to a milieu of a lot of steroids in the system, then you can jump from pillar to post later on. You will not be able to control the disease, and they will take away the eye. So that's like adding huge amounts of fuel to that fire, which is called AN, which became BAN in this patient because of delay. And then, not only was there delay, but there was, the worst thing possible that could have been done, which was systemic corticosteroids.
So in such kind of cases, when do you consider intravenous as opposed to oral therapy? Because it was bilateral involvement and they have stuck on to the oral therapy.
Yeah, well, there is some data now to suggest, and mind you, that data is from the US. And that data suggests that it's actually comparable, the outcomes. If you give intravenous, which is you admit the patient, you give intravenous, acyclovir, which is thrice a day, versus oral, either valacyclovir or acyclovir, depending on what your preference is and what the patient's affordability status is. And they've actually looked at the outcomes, and they've said it's comparable. And following that, most people now tend not to admit. Mind you, you also have to understand that in the US, a lot of the treatments, apart from those big institutes which aren't opening every second day in that country, most ophthalmic practices, group practices, even big high volume practices do not have access to admission beds. So a lot of the I'd say soft guidelines come from there. And so what I would say and what I would suggest is, and this is what I do, we used to admit all patients of ARN. This is PGI. We have the luxury of having indoor admissions and the ability to do that. In COVID, that practice changed because that was a bit different. So now what I tend to do is, if it's varicella zoster virus related on, I admit. If it's bilateral on, I admit. If it's a monoocular patient, I admit. If it's a systemically immunocompromised patient, oblique, iatrogenically immunocompromised patient, let's say a Wegener's, a GPA patient or a renal transplant or a HIV, I admit. Anything else, I will not admit, but the patient has to understand that I have to see the patient every 48 hours. So if the patient's happy to come back, they know what's going on, fair enough. If the patient, and sometimes it's not an option for patients unless, because they feel that coming back, if they're coming from a distance. So sometimes it's a patient factor, but you'd rather err on the side of admission and giving IV drug rather than relying on the patient taking all of those pills. The patient might not take them. There might be a compliance issue, especially if the patient cannot afford and the patient is taking acyclovir and not valacyclovir. You have to take it 5 times a day. Now, 5 times a day means you have to wake up in the middle of the night and early on in the morning. Most people don't do that because they feel ek dawai se to kya hi ho jayega. So it's a ticking time bomb. So if you can, you take that compliance issue out the picture, and you try and admit, and under supervision and monitoring, you try and give IV acyclovir. I would do that. And I think
so there are a few questions in the chat box. What is your take on intravitreal therapies in such cases?
Yeah, I was coming to that. So I think there is greater interest now in intravitreal therapies. I think I'm a firm believer of adding on intravitreal therapies in ARN patients. The data which is there, again, majorly from the West, is for intravitreal foscarnet. And also, it's majorly for VZV. Now, mind you, VZV-ARN and HSV-ARN are a bit different. VZV-ARN on all parameters ARN is explosive. VZV-ARN is much more explosive a disease. It's also more rapidly progressive. The optic atrophy, the chances of the other eye involvement, the chances that the retinitis will be more clock hours of the RD being difficult to settle, and post-RD complications in VZV-ARN are more. So VZV-ARN is definitely bad news compared to HSV-ARN, right? So if it's VZV-ARN, and that's why the dosage of your antiviral is also more, right? When you want to treat VZV-ARN. So for me, we have very minimal, if any, 2 patients actually, one of mine and one with Dr. Vishali's with, this is regarding foscarnet, which we use as add-on therapy. It's difficult to get in our country. You can get it. In fact, if you were to search on India Mart, you can get it from Bombay and all of that, but it's expensive, and it's not that easy to give. Just getting it off the shelf is not an option. Our infectious disease people, our pediatric, if our kids get, let's say, HSV encephalitis or VZV related encephalitis, the pediatricians don't give it. So it's not like our infectious disease people are using foscarnet and it's easy for us to get it. So that's one. So my experience is with intravitreal ganciclovir. I definitely give it in immunocompromised patients at the get-go. I give it in VZV at the get-go, along with, if it's VZV, I gave 1.5 gram TDS of oral valacyclovir and not 1 gram TDS. if I'm treating orally. I do not start steroids at the get-go. I start steroids day 3 after I've loaded the patients, so to say, with a lot of antivirals, and I have seen at least some evidence, an unequivocal evidence, fundus photo every day, of stabilization of retinitis, and then I add on steroids. Steroids which I add on are 0.5 mg per kg, unless the patient is a renal transplant or already is on, let's say, GPA or whatever for the underlying illness. That's actually a separate story. But I add it on day 3. I also, as I said, VZV, I give intravitreal ganciclovir. By BAN, I give intravitreal ganciclovir. If the patient at day 3 is not getting better, I'm not starting steroids. I'm adding intravitreal ganciclovir, and I hold on steroids longer. So that's what I do. And the intravitreal ganciclovir, you can do 1 milligram, 2 milligram, or 4 milligram. If it's VZV, I go whole hog. I go high, extremely high dose, UHD, which is the ultra high dose. I go 4 milligram.
So,
Any
quick
analysis
question.
of toxicity?
Yeah. Sir, is there any way to clinically differentiate apart from the aggressive part between VZV and HSV?
Yeah. So short answer, no. More nuanced answer, you can look at things. So if you get a porn-like picture, which, mind you, the line which was drawn, since time immemorial in our textbooks between an and porn is blurred. It's hardly a line. So you can get immunocompetent and immunocompromised. You can get pictures either way. And it depends on what level of immunocompromised status you are. It's not like you're immunocompromised and you're not. It's like if you're retropositive, you could have CD450, 200 to 250. You're immunocompromised, but it's not the same, right? So that is one. The other, sorry, I forgot the question.
Clinically differentiating
Yeah,
between.
sorry. Yeah. So and the other thing is, so if there is remarkable lack of intraocular inflammation, which means no KPs, hardly any cells, minimal, if any, retrolental cells, media grade 1, everything is crisp, right? Then you should definitely try and think and try and look at that the person's body is not able to mount an immune response, right? So there aren't cells happening there. So that is something that you can try and look at. But if you want to try and differentiate between VZV and the other, clinically, apart from a porn, so if you get a clear-cut porn, I think it's VZV for the most part. Apart from that, I think it's extremely difficult, unless, of course, you have a history of. So it's very important to ask कि यहाँ पर कुछ like dermatomal, herpes zoster lesions, and all of that. Also, you must consider in some of these immunocompromised patients, and I've seen this in 2. It's rare, but you guys might get to see it. So I had one patient of GPA, the other patient of polyarthritis nodosa. Both ladies, being treated, and they had very aggressive disease, systemically, multi-system involvement, were on biologics. One of them traveled abroad, son, well-to-do family. Someone said, that you can get shingles. So now there is a shingles vaccine. Let's give you a vaccine. Now, mind you, the shingles vaccine, the varicella zoster vaccine, and people will come and ask you this, is a live attenuated virus. It's not a dead virus. Now, if you're immunocompromised, right, these vaccines aren't for you. Now, I don't want to say who it was in the Western developed world who did that. That patient developed PON, VZV induced. She lost one eye. She was flying back. She was made to quarantine when she was in Europe. She couldn't take a flight because her eye was red. She lost the other eye. So what I'm trying to say is, please do not. So varicella zoster virus vaccine is great, especially if there's someone who's actually had on PON or whatever. They have family members or other people saying कि हम ये लगा लें. सबके लिए नहीं है. It's a live attenuated vaccine. Please don't give it to patients. So the typical high risk, which is people who are on renal transplant, it's not for them.
I just want to clarify. I think you mean the Shingrix vaccine, which is the live attenuated one.
Yeah.
India, we also have the Zostavax, which is actually the killed one. That probably is okay to give.
Yeah, that's actually okay to give. The only thing is that That's a bit more difficult to get. Now, if you were, you have in fact two versions of the live attenuated. The kids get I mean, they have to pay out of their pocket. It's not part of the universal immunization schedule, but they get the MMVR. So mumps, measles, rubella, and the varicella zoster. So that's actually ideal, and that's live attenuated for kids. But for adults who are predisposed, who are high risk, it's actually an issue. It's actually meant for people who work with primary caregivers. So if you work in an infectious disease clinic, if you're someone who does tropical disease, if you have someone who has a ton of patients who come in who have all of these things, and or you're working in a pediatrics infectious disease, it's actually for those healthcare workers, right? Because whose baseline immunity is okay.
Sir, I wanted to ask one more question. You did mention about the dose of intravitreal ganciclovir. I also want to ask about the frequency. How frequently do you repeat the IV ganciclovir?
Yeah, so if it is BAN or if it is VZV related, which is generally the two subgroups that I tend to look at, I also tend to inject, irrespective of etiology, if it's more than 50% of the retina involved with the retinitis, right? I still tend to. So these three things I will inject every 3 days, so twice a week. So typically the protocol that I would follow for CMV retinitis in immunocompromised, but it'll not be twice weekly till the lesions heal, and then weekly till the CD4 count gets better, because that's not the thing. Typically they would require between 3 and 5 injections. I think generally 3, maybe 4, because even if you're giving an IV dose, it's generally 14 days. And then you want to try and switch over to whatever else your thing is. So that would typically be time for 3, maybe 4 injections. But if you're not getting your thing with ultra high dose 4 milligram 0.1 ml, 3 injections over 10 days, along with your IVMP, sorry, not your IVMP, your IV acyclovir, well, then either it's drug resistance, or there is some, or the patient has a ton of periocular steroid, which is very bad news.
And I wanted to ask the one question, that is there any role of serum CMV, IgM, VZV, serum HSV antibodies in this cases? Any role in diagnostics?
No. So again, AN is the clinical diagnosis. It is absolute ophthalmic emergency. And the idea is, as we saw, the idea is firstly to prevent fellow eye involvement. Then secondly, depending on what the status of the presenting eye is, to get that better and prevent detachment in that eye. That is the order of, your priority. So your first priority is to prevent the other eye involvement. So you're not going to, because it's a clinical diagnosis, because there is hardly any diagnostic dilemma unless there is, atypical cases, which is a small minority. You do not rely on, and the 3 or 4 group, viruses that cause it. They're all DNA herpes group of viruses. You can get mixed infections sometimes. You can get Epstein-Barr. You can have 2 viruses or whatever, but you will you can get rarely toxoplasma RN in some patients. Maybe if I can share my slide sometime later, I'll show you another variation that you might be able to get. But for the most part, it is clinical. Please don't waste your time and the patient's resource on doing serum IgM, IgGs. If anything, poke a needle into the aqueous, get some. If you have the ability with lab facilities, I think aqueous PCR works well. Unless you're doing intravitreal ganciclovir, then you can try and take a vitreous. Otherwise, I'd be wary in a disease which has almost a 1/3 to 40% chance of a detachment with significant vitreopathy to be poking needles at the back of the eye, when the front of the eye in a pan uveitis with aqueous being there and the little amount of volume that you need for the PCR, I think works just fine. So you can actually, even if you're doing intravitreal injection, just detergest the eye by taking an aqueous tab first, send that for PCR, and then give your intravitreal. And the only difference that's going to make, it's not for diagnosis, that it'll do 2 things. In atypical cases, or in borderline cases, or in cases which are partly treated, it will ensure that you do not have dual infection. And it can tell you HSV versus VZV. If it's VZV, your dose goes up. And for me, I add on intravitreal therapy as well. So there is a diagnostic difference. there can be a prognostic difference also, and depending on your counseling and all of that, but that might not be there for everybody. But if you do not have access to AC taps or PCR, please do not refrain from treating. It is not a must to diagnose and treat. It's an addendum with a few incremental benefits. It's not a must-have.
And sir, what is your take on demarcating these lesions with the lasers in periphery?
Yeah. So as far as prophylaxis is concerned, now after you treat these lesions, what typically happens is, as happened in this patient also, as Dr. Ashwin pointed out, that they will because of the vitreopathy, they will get a posterior vitreous detachment, which will be incomplete to begin with. So a lot of that vitreous will come and settle behind the lens. So the patient will actually, the lesions will start to get better, but the patient will drop vision, because he has now a ton of that mucky, dirty vitreous, which is now in the pupillary area. And because it's incomplete and the retina is friable and necrotic, and that's the time when it's actually going to start to pull. And depending on where you're at, between 2 to 4 to 6 weeks typically is when you'll get the detachment of the retina. It can happen at the get-go. Necrotizing retinitis is full thickness. You can get retinal detachment with active retinitis also. But if you want to try and prevent retinal detachment, which is the idea, right? You can do two things. You can do, one thing that you said, prophylactic barrage laser. The other thing is prophylactic vitrectomy before the RD, right? Now, prophylactic barrage laser should not be done. There is a technical issue doing it. Media is not great. You don't know where all those lesions are. It's like shooting laser in the dark. The retina is healing. It's not healed. It's friable. Your media is not great. There is an inflammation interiorly. The lens has some haze. Inflammation posteriorly, and so the entire odds are stacked against you. So, and you don't know what to barrage and what not to. That's one. Two, even if you're, you have like 6x4 eyesight, and you can, like Superman, look through all kinds of walls and this, that, and the other, and you're able to pump in laser exactly where you want it to. You cannot treat all of the retina. You can get, because you're not treating you're actually trying to demarcate posteriorly. You can get a break within where that healing happened. And if you get a detachment then, and you've lasered, then you've made your matter worse. Because if you need to cut the retina, which you sometimes need to when you're doing surgeries for them, then you need to cut a lot more posteriorly. So you're left with a smaller island than you would have. So prophylactic barrage laser, no. As far as prophylactic vitrectomy is concerned, I think there's a role there. I wish I had some personal experience on that. I had an opportunity to do it in one patient. The patient refused. Educated my colleague, my in fact senior in PGI, his chemistry teacher in school, and also the head principal. Granulomatosis GPA patient got VZV-ARN in one eye. And mind you, she came with a BRVO to a doctor in her native city. He diagnosed as BRVO, injected Razumab, and well, there was a ton of stuff that happened. So had a lot of retinitis there, came with early involvement of the other eye. So we were able to save that eye. This eye got up to counting finger 1 meter, but then she had that phenomenon of the vitreous detaching and going behind the lens. I offered surgery to her. And of course, but she was GPA, lungs involved, this, that, and the other, educated, well-to-do, but her systemic condition didn't allow. But I would have, and she had a detachment in that eye that we couldn't fix because she refused surgery. But if it's VZV and you and the patients, let's say, admitted with you, and you're doing IV therapy, let's say 6, 7, 8, 9, 10, 11, 12 days after therapy, you get that PVD. I think there is some merit in considering a prophylactic vitrectomy at that stage, clearing up the vitreous. That also has certain nuance, whether you still want to put in oil, but it prevents RD, protects the posterior pole to some extent, but please don't be gung-ho in it. It can't be for beginner surgeons. And when in doubt, please don't jump to vitrectomy, but no prophylactic barrage laser to prevent RD, please.
And
So if
sir,
you're planning
what is your
vitrectomy,
endpoint of
sorry.
antivirals?
Yeah,
Endpoint of antivirals.
Yeah, so the endpoint of antivirals actually cannot be set in stone for infectious disease, especially with this. So if you're giving IV therapy, I'd say 14 days IV therapy, then you switch to oral. Oral therapy, at least for me, is minimum 3 months, and then I don't taper for 3 months. I then quit cold. I mean, I make the patient stop cold turkey. And so, that's that. Unless the patient is, again, as I said, GPA or has an underlying immunosuppression for which the patient has to be on suppressant for a pretty long time. So at least 3 months. Some people give it for 6 weeks, but I'd say that's more for something like a toxoplasma, which is milder. But for AN, which is aggressive, fellow eye, and it's, all over, I'd say definitely 3 months.
Okay. Thank you so much, sir. I think we have covered all the questions. So, sir, if you would like to share few cases, then we would be very happy to see that.
Sure. Thank you. Yeah. Is my slide deck visible?
Yes, sir.
Yeah. Great. So again, please feel free to stop or ask me or whatever. So these are not your typical run-of-the-mill cases, and you'll see why. I just threw some of them together because I thought it was important to try and look at what's going on and how. Sorry. Yeah. So case is a 66-year-old Indian male presented with decrease in vision in the left eye, gradual onset, progressive, painless. The diabetic, had coronary artery disease, was being treated as a case of left arm with oral antiviral since 2 months, and was referred to us for no response. So anything here that rings a bell on this slide, I mean, I have no photo on this slide, but anything that rings a bell which is off. So yeah, so there is no, it's acute retinal necrosis, for crying out loud. There is no AN which is not going to show response in 2 months. In 2 months, if the RN is not responding, then the eye is in either phthisis or has a detachment. The visual loss will not be gradual unless gradual and progressive. तो ये slide is telling you कि या तो मैं गलत बात कर रहा हूं या जिसने भेजा उसने गलत बात की है. It can't be on if this is the thing. It's not choroiditis, right? So that's what the patient had. Now you won't fault you. It's very difficult to fault the person who ever said this. Sent this this could be porn, right? Right? I mean, anybody has any other things to say. If you were to look at these lesions closely, right? They aren't. So they're actually multifocal. If they are 2 months, they're not getting better. They need to tend to get. They should be getting together. And if you were to look at this, it's elevated. Now this is elevated, right? Now, AN is necrosis and with time atrophy. There's no point of, unless you get a detachment, there is no elevation that's happening. So fluid वगैरह तो इकट्ठा नहीं होगा इसमें, right? And that's that. You can see something happening there. There's a leopard skin appearance. This is not AN. This is not porn. Elderly man. That's your OCT. You can see this is sub-RPE. The retina is fine. Whatever's there is there. Isoto hyperreflective sub-RPE deposits. So anybody wants to venture a guess what that could be?
This is lymphoma.
That's lymphoma. That's absolutely. This case is actually from my second year of senior residency. I remember this case distinctly like the back of my hand. So yeah, so this was a clinical diagnosis that we made at that point in time. Of course, then we went on to, this patient underwent biopsy and this, that, and the other, and we treated. With at that point in time, we were only doing methotrexate and not rituximab, but this patient got better, and that's what this patient did. So you can have in the elderly, they can mimic, right? So another patient, 46-year-old female, being treated elsewhere, similar on past 2.5 years. She was an aunt of my PG at that time, right? So she came with the VIP tag for us people, right? हमारे PG की aunt है. That's what she had. 624 AC cells, KPs, vitreous cells, big necrotizing retinitis patch nasally, right? Vitreous haze. There's something happening there. You can see that, lots of hemorrhage. This could be CMV, right? Hemorrhage is out of. That's what you see. That's the OCT passing through the lesion. Just keep in mind what that is, right? That is rounded, right? Okay. And so we're seeing what's happening. Mind you, 2 महीने से 2.5 महीने से ये एंटीवायरल ले रही है. ARN 2.5 महीने चुप नहीं बैठता. It's aggressive. It's against the natural fitrat of your DNA virus, right? Now, if you were to see here, there's nothing happening there. But this is a couple of weeks later, and you see there is a subretinal whitish hypopion, which is there. Can you see that there?
Yes.
There is appearance of that there, and there is 17 days later, there is an appearance of another lesion right there, which wasn't there. Now, this is not on. It's below the retina. It's definitely not PON. You can see the hyperreflective material there. And this is, as you can see on the OCT, there is this, so there is thickening of the retina, and there is there is some vitreopathy there, and there is the hyaloid is partly detached and stuck there, and there is this rounded roof configuration which is seen on the OCT, right? Old school, हमारे तो roofs ऐसे नहीं होते, but गोरों के होते हैं. They have that rounded roof configuration. This is lymphoma. And why you know this is not on and in the first slide is because 2.5 months, no one's gonna sit indolently. It either gets better or gets a detachment or undergoes optic atrophy or phthisis. इसमें चौथी चीज नहीं होती. 2 महीने में the story is over, this way or that way, right? So this patient similar. Again, we did surgery, and this patient turned out to be lymphoma. It's going to show two small cases, and then I'm going to stop my presentation. This is 50-year-old female, diminution of vision, right eye, 1.5 months, associated with pain, history of trauma to the left-hand childhood. She came from Kashmir. So unfortunately, had some pellet injury in the left eye way back. That's what she said, lost the left eye. It was diagnosed as on, treated with oral Valsivir and 40 milligram Vizolone for 3 weeks, and then received PST Canaccord. I think this doctor was maybe a step ahead from the doctor that maybe referred the patient to Dr. Ashwin, because the doctor didn't believe in IVMP, just gave a PST Canaccord, and was no response. So if you diagnose on and give PST Canaccord for no response, so honestly, as my boss would say, and as I would agree, degree le leni chahiye. Your degree should be on the line, honestly, if that's what you're doing. But chalo. So hand motions, 1+ cells, right eye, left eye was physical, no PL, PSC cataract. That's what the patient had. So multiple yellow lesions, periphery, vitreous hairs, AC cells, right? That's what the OCT is. Anybody wanted to look at or trying to venture क्या है या क्या नहीं है? क्या है तो किसी को नहीं पता. It's not on.
No, it's not.
It's not on because you can see that these are discrete, these are elsewhere, and you can see that some of these are following the retinal vessels, these
Retinal vessels.
and there's something happening peripapillary, and here you can see this hyperreflectivity here. So this is fibrosis, which is corresponding to that yellow area. Now, viruses cannot cause fibrosis. Fibrosis cause atrophy. They cause holes. They do not cause fibrosis. This is fibrosis. So this is not on. This patient's left eye was physical. That's what the FA showed, and you can see some of those those things along the retinal vessel. So this is not on. There is no occlusion happening anywhere, right? So vitreoretinal lymphoma, atypical. Was it syphilis because you had outer retinal involvement? Although that doesn't happen. Was it atypical sympathetic ophthalmia? The other eye was lost, right? It doesn't look like sympathetic ophthalmia. We took an informed consent, and I'm big for this, right? If you don't know what's happening, and if there's a defunct eye, you try and get it out to help solve a problem which honestly I didn't know the answer for. So we got the left eye out. The lady was consented, and that's what the report showed. So this is granulomatous chorioretinitis with some of those cells which are distributed not only in the choroid but along the retinal vessels. So this is a rare but extremely aggressive form of sympathetic ophthalmia. So it is not a bilateral, it's not a granulomatous and uveitis which looks like VKH. This is a fibrosing or a sclerosing variant of sympathetic ophthalmia, in which sclerosis comes early. It mimics on because it has those yellow lesions in the periphery. There is vitreal involvement. And most of these cases which have been diagnosed in the world, which are only a handful, the eyes have been lost because people have thought that that this is that this is on, and they have treated as such, and later they have felt it's not getting better, they have done surgery. Now, if you do surgery in a sympathizing eye without giving immunosuppression, those eyes go like that. Right? So this is what this patient had, and we were able to restore some semblance of, and this haze is because of cataract. So this patient got better, and his 3/60 continues to be 3/60 4 years into this. But and you can see there is some subretinal fluid, and that's gone away, and you can see that fibrosis is much better now. Just going to show one patient, and this is the last one in the series, and this is just to show and talk about the steroids. The 30-year-old female came from Rishikesh, progressive decrease in vision, right eye, had received posterior subtenon Kenacort injection for inflammatory disc edema. It's a known case of pemphigus vulgaris, and was on systemic treatment for this. Yeah, so these were already sent to me by the doctor who would. This is what she had. Was given PST Kenacort, that's what she got. So even if one looks at this and says this is optic disc granuloma, which one might not be wrong in guessing, please don't give PST Kenacort, because even if you're saying it's tubercular, it's infiltrative, it's metastasis, it's whatever, it's not something you see every single day. It's unilateral. Please sit on it. Otherwise, you make it into this, which is dual infection. So now you have the whole shebang. Now you have optic disc, occlusions, arteritis, venular involvement, and you can see the intraretinal hyperreflectivity. Definitely a tap in this, because this patient is now systemically immunosuppressed and periocularly immunosuppressed, because the PST Kenacort had dual. And we were able to do something for her, but of course, and she did fairly okay. We were able to do scatter laser and preserve the eye and give her some semblance of vision. But the idea is, please do not give, and we talked about this earlier, systemic or periocular or intraocular steroids if you don't know what's going on. And especially if it's unilateral pathology, please hold your horses, hold the urge to be trigger happy injecting or giving systemic high dose steroids. Yeah, thank you.
Thank you so much, sir, for sharing your atypical cases with us. And I think the last question in the chat box was this case, Dr. Ashwin's case, why they went for vitrectomy with oil. So
yeah, well, I
I
would
have
like
two
to
questions. Yes, regarding that, sir, I have two questions. Like, what is your take on, like, is it going to be isolated PPV, or like, do you prefer putting a belt in these cases? What is your take on that? And second thing is tamponading agent. Do we put in oil or not? Or if not oil, then what else?
So I'll answer I'll try and answer the question which ideally should be posed to Dr. Ashwin regarding why PPV was done. I don't think PPV should have been done there, but I understand bilateral, youngish male, PL. You're absolutely pushed against the wall. So it was, I'm guessing, and please correct me if I'm wrong, Dr. Ashwin, more of an emotional decision and almost like a last ditch effort than a scientific rationale one. And honestly, I don't think it should have been done. I think, but I'm guessing that was the reason why it was done, Dr. Ashwin. Could you correct me if I'm wrong?
Two reasons. One was that yes, the patient really was quite desperate that he wanted some intervention from our side. But another reason being the vitritis started worsening, and we were also wondering that if we let it go like that, that patient can come back with a retinal detachment. So kind of like a prophylactic reason why we did it. And then while you're answering this question, you can also answer what will be your choice of silicone oil in case you're going for surgery. Will it be 1,000 or 5,000? What would you prefer, sir?
Yeah. So again, Dr. Ashwin and Dr. Dipanshu's question, I'll try and answer together. That is, so we have some work and some published work on CMV retinitis related retinal detachments and ARN related retinal detachments. I think for ARN retinal related retinal detachments, one needs to differentiate. Make two different kinds of subsections. One is the more common variety, which is seen in about 80%, in which by the time you get a detachment, there is no active retinitis. So the retinitis is healed, and you're getting, the PVD has happened, and then you start getting multiple tiny holes, and that's what's the cause of retinal detachment, which is most commonly seen. That happens later, 6 to 8 weeks, sometimes 2 to 3 months after the acute event. The second one, which is more serious, is when the retinitis is still active and you get a retinal detachment on top of that. That is thankfully much less common, in only about 15-20% cases. Now that is very difficult, and in that, of course, you want to try and wait for 5, 6, 7 days, try and treat more aggressively because you want to try and get the retinitis to heal as much as possible before you want to try and fix the retina. In those patients who have retinal active retinitis with retinal detachment, I tend to use infusion fluid during vitrectomy, acyclovir in a dose of 30 microgram per ml. So active retinitis RD, infusion fluid, the BSS during vitrectomy, the entire vitreous and the retina keeps getting bathed in that. And there is some data to suggest Dr. Holtkamp's work from early 90s, and there is Dr. Ghulam Payman, the legendary Dr. Ghulam Payman's experimental work late 80s, on the dose and that. So that's what I do. So that helps with the healing process of the retinitis. Mind you, in those patients, you almost always need to cut the retina. Active retinitis RD outcomes are generally poor, and most of the time those will be VZV, so optic nerve issues, and so outcomes in those are poor. In those, I will not put in a band because I know in them active retinitis there'll be some to considerable retina that will need to be removed. So no band in them. Definitely oil in them, not 5,000 centistroke oil. The only exception being that if it's CMV retinitis related RD and it is a HIV patient who might. So it was always 5,000 centistroke oil for CMV retinitis related RD in HIV people. Now no longer the case because heart is much better. Availability through the NACO government centers of heart is much better. So even patients who are below poverty line who cannot afford, even I've seen considerable change in the last half a decade with the immunity of those patients getting better and even their life being longer. So they will outlive the life of the oil. So 1,000 centistroke for them also. If it's a Bahn patient, one eye is gone. If it's unilateral, it's a monocular patient, and I'm doing vitreous surgery, then I put in 5,000 centistroke oil because generally in these patients, redetachment after oil removal is not as big of an issue as is hypotony. So once you get the oil out, hypotony with oil and after oil removal is the bigger challenge. So in them, I want to, monoocular patients, I want to retain oil longer. If a patient had good vision, had healed retinitis to begin with, and got 6 to 8 weeks later PVD related detachment, I would put in a band. Active retinitis, I would not put in a band. I would try and avoid retinectomy if I'm putting in a band, and it's generally a more broader element. It'll 241 or 242 and not a 240. And almost always the choice of tamponade would be oil 1,000 centistroke, unless monoocular, then 5,000 centistroke.
And sir, when you plan for silicone oil removal, what subset of patient do you just exchange the oil
Yeah,
and never remove the oil?
yeah, that's a tough question. Yes, there are certain eyes which will unfortunately be silicone oil dependent forever. So if your pressures are low single figures, even with oil, right? So let's say 6, 7, 8 with oil in the eye, retina attached, everything's okay otherwise. And of course, there'll be disc pallor and this, that, and the other. Well, then you almost have to feel and that you can remove the oil, the pressures are going to drop by at least 2 to 3 more millimeters, which is going to push the eye over to a hypotonic metalopathy. Sorry. So for those eyes, it is exchanges. The exchanges for how long, I don't know. But if they get 1,000 centistroke oil to begin with, the second time around post emulsification, they will get 5,000 centistroke oil and better quality. So let's say if I were to use an Indian company, oil, if I were to go to 5,000 centistroke, I'd use leptician because not only is it 5,000, it also lasts longer. You want to try and maximize that as much as possible, but not for every patient. Not for every patient. A small subset, even with good pressures, where the oil can yet go into hypotony post oil removal. But I won't recommend doing UBMs for all prior to this. I think you can get soft feelers with the oil being inside the eye and with intraocular pressure. And if you start getting early BSK formation, which you're seeing with no other reason, then you know that that's going to be an oil dependent eye. And especially if it's a VZV patient to begin with, you tell the patient at the get-go कि इसमें multiple जरूरत पड़ सकती है and पता नहीं निकाल पाएंगे कि नहीं.
And so when you operate in these active retinitis eye and it is an oil-filled eye, do you change the dose of your intravitreal injections later? If it is in the active stage still?
So I'm guessing you're saying the second rarer subset in which you have active retinitis with a detachment. We try and we try and fix that. We cut some retina, we put in oil. So typically in them, because I'm using infusion fluid, ganciclovir, and systemic ganciclovir will continue. Healing of the lesions is not a problem. So I don't have experience, and I don't think one would need to top up your systemic acyclovir with intravitreal ganciclovir in them, unless that happens sometimes in CMV retinitis. Patients who have ongoing systemic immunosuppression. In them, yes, I've given injections under oil. But I would typically not reduce the dose to 1/4. I would half the dose.
So will you give the injections more frequently if it's under oil, or do you change your interval between the injections?
Is that CMV or this?
For both. Like if it's an audio.
No, again, as I say, I think it would be absolutely exceptional, almost to the point of not needing it ever in a AN patient under oil for you to be injecting ganciclovir. For CMV retinitis with ganciclovir, especially HIV positive, patients with extremely poor systemic control of disease, right? That's a big issue. So in them, you sometimes need to give ganciclovir, and in them. In fact, the frequency is lesser because the clearance of the drug is actually more. The clearance of the drug, is slower. It stays there longer. So I will not treat. I will treat once a week and not twice a week. So not more frequently. In fact, less frequently.
Thank you, sir.
Okay. Thank you so much, sir, for all your thoughtful insights and expertise on this topic. Will you summarize 5 important points for surgical part in ARN?
Yeah, sure. So again, I'd say I think it's very important to consider the two different kind of arms of ARN detachment. The commoner one, and thankfully that's the commoner one, is the one that you will see after the retinitis is healed and you get vitreopathy as the predominant thing. So that's a healing response. And that will typically happen 4 to 8, maybe 10 weeks after the onset of retinitis. In them, the issue is settling the retina with multiple breaks with retinitis healed and no active retinitis. The other one is when there is active retinitis, and the patient sometimes will come to you because they had some retinitis in the periphery and the retina detached. So active retinitis and detachment. Now that's bad news. That is aggressive. So first is to keep these two to identify and keep these two separate. If you were to deal with the second part, active retinitis with retinal detachment, prognosis is poorer. You should discuss with the patient that this might be oil-dependent eye because you will need to do primary retinectomy. You need not put in an encircling element in this patient. And because it's active retinitis, you can try and buy yourself a little more time and not rush into vitreous surgery. To give yourself 5, 6, 7 days of IV therapy, even with detachment, to try and cause some amount of healing of the lesions, and definitely use infusion fluid BSS 30 microgram per ml ganciclovir as an adjunct during surgery to ensure that your lesions are healing. If it's the first kind, which is, again, as I said, which is more commoner, I would definitely put in an encircling band, a broader element. I would try and avoid retinectomy or minimize retinectomy as much as possible. These eyes generally have very well-formed thick vitreous. There is vitreoscheisis, but you are generally able to make it out with with instilling triamcinolone. Please don't be gung-ho about peeling ILMs in these cases. The macula can be atrophic. The disc is pale. Please try and do an efficient, quick job of vitrectomy and get out of that eye, because these eyes, the optic nerve is compromised. If you keep jacking up pressures and keep taking forever till the cows come home and spend a lot of time during vitreous surgery, that's going to add to the ischemic damage to the optic nerve, some of which you can't help in the first place. Always try and use oil. You do not need to jump to 5,000 centistroke oil. Please use 1,000 centistroke oil. If there is hypotony or low pressures, low single figure pressure, even with oil in the eye with retina attached, or there is formation of hypotonic megalopathy or BSK changes, or if the patient had active retinitis with RD to begin with, or if the patient had VZV, any or multiple of these factors, there is a considerably higher chance that this will be a silicone oil dependent eye. So you will need to replace the oil. Once you get the oil out, you need to replace it with a 5000 centistroke oil and then keep it there for a considerable length of time and not treat it like a garden variety, PVD induced RD in which you want to try and remove oil before things are happening. Glaucoma is less of an issue in these eyes. Some people, there is some data that, once you fix these eyes, they can get some CME later on, and you can treat that with intravitreal Ozurdex. Please refrain from that. There is good data from good centers, from top people in the country, absolutely. But please refrain from injecting intra or periocular steroids. A patient who survived on with or without a RD can live with some CME for some time, please. That's the least of the worries. I think you will have a bigger worry if you're injecting steroids in and around the eye than the patient. So, yeah.
Very important point, sir. Yes. Thank you so much, sir, for all your questions. You answered everything with such a clarity that this discussion will be helpful to all the fellows and young ophthalmologists for in their day-to-day practice. So hope everyone had a good time here. And now we are going to conclude this session. So thank you so much for all joining today. And we hope to see you soon again in our next webinar. Thank you.
Thank you. Thank you, everyone.
Thank you. Good
Thank
night.
you.
Thank you so much, sir. Thank you.
Thank you.
Thank you,
Thank you,
guys. Thank you,
sir.
everyone.
Thank you.
Appreciate it.
Thank you.